Welcome to the Dale Wolfle Lecture in Science and Technology Policy at the Evans School of Public Policy and Governance. For more than a decade, the Wolfle Endowment for Excellence has provided the opportunity for a public lecture that fosters greater public understanding of science and public policy and honors Professor Dale Wolfle for his distinguished career in service to national and international science policy organizations. Wolfle's legacy includes 16 years as executive director of the American Association for the Advancement of Science and as editor of Science Magazine. And for over a quarter of a century, he made significant contributions to graduate education as a professor of public affairs at the University of Washington, teaching courses in science and technology policy. Today, we are honored to have Dr. Helen Chu deliver the 2022 Wolfle Lecture in Science and Technology Policy. Dr. Chu is a physician, UW Medicine, and associate professor in the departments of medicine, epidemiology, and global health. She earned her undergraduate degree at Cornell, her MD at Duke, and she completed her internal medicine residency at Harvard, followed by her fellowship at the University of Washington. Her research is focused on vaccines and respiratory viruses. She's a principal investigator of the Seattle flu study, which first identified COVID-19 community transmission in the United States. I can't think of a more timely topic for the moment we're in. Dr. Chu will discuss the origins of the Seattle flu study and her work with public health departments, policymakers, and community partners to develop strategies for COVID-19 testing, viral variant sequencing, and mapping of community spread. And with that, I will turn it over to Dr. Chu. Thank you.
Great. Thank you so much. Thank you so much for inviting me to speak today. I'm going to go ahead and take off my mask up here so that you can hear me a little bit more clearly. Okay, can everyone hear? Okay, perfect. All right. So it is such a pleasure to be here today and to talk to you about some thoughts I have on public health policies for pandemic preparedness based on the work that we've done over the last 3 years as part of Seattle flu study. So these are my disclosures. And in my talk, I'd like to really divide this into 3 parts. The first is to talk about the Seattle flu study as a pandemic surveillance platform, a prototype platform that we had developed 4 years ago rather, before COVID-19 to help us figure out ways to interrupt pandemics before they spread. And to talk about how we established community surveillance and then how we shifted our response to COVID-19 and some of the work that we've done in public schools and in homeless shelters and here at the University of Washington. I'd like to talk about another study that my team has worked on, which is called Harvey, which is a cohort study of COVID-19 survivors. It was the first study in the United States to enroll people recovered from COVID-19 and helped us identify the correlates of protection for vaccine trials and help develop some of the early monoclonals for use. And then finally, I'd like to talk about where we are now and how we might better prepare for the next pandemic based on some of the lessons learned from these 2 studies. And then, of course, I'm happy to take any questions. So very briefly, I wanted to start with 1918 and compare it to where we are now. So in 1918, the population was 1.8 billion. People traveled through troop ships and railroads, and it took about 4 months for a virus to circle the globe. The preventative measures that we had in place were masks and disinfectants, and the treatments were bed rest and aspirin. Compared to now, the world population is 8 billion. People can travel by airplane, and therefore it takes the virus about 2 days to circulate the globe. We have masks, diagnostics, and vaccines for prevention. Unfortunately, we also have antivirals and monoclonals. The estimated deaths from 1918 was 50 million, or 2% of the world population. And thus far for COVID-19, it's 6 million, but we expect that to grow exponentially. So I wanted to take us back to 2018. And we were here in Seattle at the time, and we were approached by Bill Gates to start a project to understand how pandemics spread. And that was really the origin of the Seattle flu study. So at the time, it had been 100 years since the last pandemic. We knew that another pandemic was inevitable. We felt like flu would be our pathogen that would cause the next pandemic. It was also a perfect pathogen to study because it came back every year as a seasonal virus. And so we could use it as a model pathogen to figure out ways that we could potentially stop the spread of a pathogen in a city and thereby the rest of the community. We knew that current surveillance strategies in the United States were not designed to detect novel pathogens. And so at the time, the way we laid it out was that the objective of the Seattle flu study was to develop a pandemic surveillance platform that could be used to identify new pathogens and develop strategies for rapid containment of spread before the months to years that it would take for a vaccine to be developed. So back then, and things are actually very much similar to how they are now, we relied on reports from clinics and hospitals of flu positive samples that were collected from individuals who sought care. And that's the primary source of data that would come in. The data linkage between the samples and the clinical data was very, very difficult to achieve. So you could get the lab data, you get the clinical data, but they didn't really merge. And then genomic data was very sparse at the time for influenza and for other viruses as well. Critically, the approach that was in place at the time really missed individuals in the community who did not seek care. And we hypothesized that these individuals could introduce novel strains through travel, they could contribute to spread, and they may in fact provide an earlier signal of activity than people who are in the hospital or the clinic. And so we thought, can we identify individuals with flu in the community who are not care seeking and use these data to map chains of transmission? And secondarily, can we diagnose and treat flu at home, thereby preserving healthcare workers and PPE for use for the sicker patients? And so we developed a three-pronged strategy. The first was to expand community surveillance. We wanted to set up sites for testing in the community in places where we thought people might be walking around with flu, but not necessarily know that they had flu. So we went to public schools, we went to workplaces, we went to light rail stations, we set up a kiosk under the Space Needle at the Seattle Center. We wanted to study novel ways for contactless home-based testing and treatment for flu. We wanted to also build a high throughput lab that would be able to detect multiple viruses at a time and to very rapidly be able to pivot to develop new tests to diagnose novel pathogens and to use whole genome sequencing to map chains of transmission. And finally, the third piece, and I think this is a very critical piece, is that we wanted to build a data system that would then merge this clinical data and the laboratory data very quickly, so that once we found a positive sample, we could identify who the individual was. We could understand how the pathogen would spread from person to person, and then we would be able to take action to interrupt onward transmission. So the first thing we did was we just started simply collecting the samples that came in through hospitals and clinics. And this was sort of our control arm. Like this is the way that samples were already coming in. And we wanted to use this to compare against the other strategies that we would develop. So we went to the hospitals in the region and the clinics in the region. We started just bringing in all of their leftover samples. We call these residual samples. And then we expanded to all of these other sites. We went to schools, universities, and daycares. We went to homeless shelters, which we thought represented a congregate living setting, sort of like a skilled nursing facility or a prison. We went to households with families with young children. We went to public sites. We were at SeaTac Airport in the international arrivals baggage claim. And we were in public spaces, workplaces, all over the city of Seattle. And these were all the partners that worked with us. And it was a lot of work back then to go and meet with every single one of these partners and to explain to them why we wanted to do this research study. And thankfully, almost everybody we spoke to agreed to let us set up a kiosk and conduct research testing at their site. I have to say the one place that we were not able to get into, which I really think about now is almost laughable, was cruise ships. They didn't want us there. They said that they did not want us at the cruise ship terminals because they did not want people to think that you would get a respiratory infection on a cruise. So they did not want our kiosk there. But here we are, King Street Station. This is one of our banners, sniffling, coughing, aching, we need you. And people would come up to our kiosks and they would really self-refer. They would come up, we would screen them for eligibility, they would complete a consent, and they would enroll in our study as long as they had at least 2 of the following symptoms in the past week. We made the symptom profile very, very broad because we really wanted to capture people who could have novel pathogens who might present in a way that was not traditional. Then they completed their questionnaire on a tablet. We collected a nasal swab from them, and then they got a $5 gift card. We also decided that what we would do be to develop something called Swab and Sudden, which is an online way to enroll in our studies. So you would go to our website, seattleflu.org. You would click through, do your enrollment online, and then the swab kit would arrive at your house, usually within 2 hours. And then you would swab yourself and then set it outside, and a courier would come and pick it up and bring it back to our lab for testing. You would get this kit with you, and in this kit was an instruction guide of how to collect your own swab. And at the time, this was very novel. It wasn't thought that people could collect their own sample, and it was thought that people wouldn't want to collect their own sample, that they would think it was difficult, or and then there would be a lot of errors. And we wanted to prove that it was possible. So we did this. This came in their kit. They opened it up. They read the instructions. They collected their swab. They capped it. They put it in the bag, and they put it outside, and it got picked up. And then it arrived back in our lab. And in our lab, led by Dr. Starita, shown here, we would then take that sample and test it simultaneously for 26 pathogens. And these were the pathogens that we picked for our initial panel, because we thought that these were the standard pathogens that cause respiratory illness. And then we added something called pan-influenza A, which is an influenza A primer, or a way to detect flu A that was that would pick up pandemic influenza. We really thought pandemic flu would be the first pandemic pathogen that would arrive. And then we would take these samples, and then we'd get the results, and people would get a barcode. They would go to our website, enter the barcode, and they would see the results. That was also novel, and that you could get the results from your testing. So that very first year and a half, we were pretty successful. This is a graph showing all of the pathogens that we found in these sites all over the city. You can see that we found lots of flu. We also found RSV, coronavirus, all of these other viruses that were circulating in community sites. And one of the critical things that I think we found during that time was that not only did we find the pathogens, but we actually found them at the same proportion in the community that we found in the clinic. The 20% of the samples that we collected from these community sites had flu detected, which is the same proportion of the samples that were collected from the clinics and the hospitals. So we were able to successfully find people who were otherwise not accessing care, but who had flu and were transmitting it to others in the community. And so this is a phylogenetic tree, which I don't feel like I need to explain as much anymore as I used to. But this is basically showing the strains of influenza that are circulating around the globe. And this is through a platform designed by Trevor Bedford, who is one of the principal investigators of the Seattle flu study, along with myself and others. And what you can see is that there's many, many different strains of flu circulating around the world. And that year, Seattle happened to make up one of the largest proportions of flu genome sequence in the world. I think we were the city with the largest number of flu genomes through Seattle flu study. And interestingly, what we did was then we took those samples, we linked it with the clinical data, and then we were able to start mapping how flu was entering the city of Seattle, and then how it was spreading through the city of Seattle. And so that was way back before COVID. And we used this platform to really show different strains that entered, some of them extinguished and some of them spread. And so that was really sort of proof of principle. This is something we can do. We can go end to end, where we can collect the sample from the community, we can sequence it, we can get the clinical data, and then we can link it together to map how a virus would spread throughout the community. And this is the last piece of what we did before COVID-19. So one of the things that we were really interested in was whether or not you could diagnose flu at home and then deliver an antiviral to somebody's house and have them take it at home without ever having to encounter a provider. And this was really important, I thought, back then, because you want to be able to create a completely contactless way to be able to treat somebody and interrupt onward transmission. Because at that time, when somebody has a pandemic flu, what you don't want them to do is to come into the clinic, see a healthcare worker, and expose an entire clinic. So we enrolled households with young children virtually. We did this in partnership with Seattle Public Schools. We sent them text message surveillance for illness episodes. And then once they had symptoms of a flu-like illness, we instructed them to take a home antigen test for flu. And we developed this, or we worked with a company called Illum, which was developing a home antigen test for flu and now has one for COVID. And then we partnered with a telehealth company called 98.6, which is based here in Seattle. And once somebody had a positive flu test on their home antigen test, that information was transmitted to 98.6. Then 98.6 would then send a script for an antiviral to the pharmacy. The pharmacy would fill that script, a courier would arrive, and then within 2 hours, the antiviral would arrive at the house. And people were able to do this. We diagnosed 30 cases of flu in 300 households. Were able to diagnose themselves. They were able to take the antiviral. They were able to go through all of these steps. Again, sort of a proof of principle. This is something you can do if you need to be able to have a completely remote, contactless way of diagnosing and treating a pandemic pathogen. So these were the conclusions that we had learned from the first year and a half of the Seattle flu study. I think the first thing that I learned was that it takes a lot of time and effort to establish these trusted community relationships. This really involved going door to door, meeting with all of these partners again and again, and convincing them of the value of this type of surveillance. And luckily in Seattle, I think it's a community that wants to help. And so we were able to do this with many, many community partners. One of the other things we found out is that individuals are able and willing to self-collect samples for testing for flu and other viruses. That this is something that people can do if you just give them an instruction manual. Novel surveillance strategies, including home-based collection, allows for detection of flu and other viruses in the community. And then once you couple that with genomic analyses, it allows you to map how flu spreads throughout the community. And that contactless ways to diagnose and treat viruses are key, but it really requires you to be able to identify these individuals early through home testing. But you can't wait until somebody's had symptoms for 5 days for them to go to a clinic and then say, I need Paxlovid. That's not the right time. You need it really at symptom onset. And finally, all of this infrastructure really needs to be in place before a pandemic, that it's very hard to build this kind of, this type of infrastructure. It takes a lot of time, a lot of trial and error, and that all of it has to be in place for you to be able to respond effectively. So I wanted to move on to the next part of the talk, which is about how the early days of the pandemic here in Seattle. So if you remember, Seattle was the site of the first US case in Snohomish County. And that was when Seattle flu study really got involved. And the first sort of news of this came through that New York Times article where coronavirus was shown to have circulated in the US for several weeks, what we call cryptic transmission. So 6 weeks of transmission in the Washington state area. And that was based on the samples that we had collected from Seattle flu study and this infrastructure that we had built. And so fortunately, Ethan Sachs, who is a writer, he wrote for Marvel Comics, created a comic about the early experience of the Seattle flu study. So these are his images. And I wanted to sort of just go through the timeline of events that happened back in January of 2020. So on January 21, 2020 was the first US patient. I remember this because I was at the NIH at the annual vaccine trials unit, and Dr. Fauci was giving us a talk, and then we all got the text message that the first US case was in Snohomish County, Washington. I came back from that meeting. I sat in a room with Trevor and with Leah and with all of our team. And Trevor told us that we were headed for the next 1918. Of course, none of us wanted to believe him because who wants to believe that? And so the very next day, we started discussions with CDC, with state and local health agencies about, how can we help? We have this pandemic surveillance platform that we've built. We have all these biospecimens. We have a state-of-the-art lab. What can we do to help? And the very first thing we did was that we said, well, let's just build the assay. Let's just build a PCR assay. This isn't that hard. Everyone's going to have one. Why don't we just get ours started? So Leah built the assay, and then she had it up and running in 2 weeks. And then on February 5th of 2020 was when FDA issued the authorization for testing to CDC for public health labs. So that was quite a bit after the first US case was diagnosed. And in this intervening period between January 21st and February 5th, the only way that you could get a test for COVID was, if you remember, that you would collect a sample and it had to be a traveler and it had to be somebody with a fever, and then you would send it to Atlanta. And then it would get tested and then you would get the results back. So that was like a 5 to 7 to 10 day delay before you actually had those results. And so on February 5th, they issued the authorization. So at that point, local labs could test, local state labs. The problem is that the test was a faulty test. It kept on producing invalid results because of a contamination of one of the controls. And so even though a test was available, it didn't work So that went on for several more weeks. And this entire time we were having discussions with CDC, with FDA, with local and state public health about, what can we do? We have a test that works. We had a test that was working by February 7th. Can we start testing some of these samples that we've collected in our studies and help answer the question of whether or not it's present in the United States? And so on February 25th, we did finally receive permission to test samples. And of course, 2 days later, we had our first positive. And that was from a teenager who had no recent travel and had no epidemiologic link to the first US case. And so we knew based on that information that essentially that there had been ongoing transmission. And then we did sequencing of the sample over the next 24 hours and were able to confirm that indeed it had been spreading through the community. And then 2 days later, and in this intervening period, we had multiple discussions with FDA and CDC. FDA issued a pathway for clinical labs to be able to do testing. So it really expanded the opportunity for others outside of the public health lab to be able to test. And also at the time, by then, it was possible that they had fixed the problem with the contamination. And so the test that was used by the state health labs was valid. But that took over a month to get from the first US case until we had an operational system to test for COVID-19 in the United States. So I wanted to just spend a little bit of time on that very narrow time period of, the day that we got the result and what we had to sort of think about at the time and how we made our decision. So we knew that it was a recent sample and that it had a high viral load. So it had been just collected 2 days earlier. We knew that no widespread testing was available at the time. And we thought that the individual could get sicker and it could have substantial risk of transmission to others because we knew that if you were sicker, you had a higher viral load and you were more likely to spread. Our lab was not clinically licensed. We were a research operation. We were therefore not permitted to return results to participants because we didn't want to return an unvalidated research result. And also, that particular very first sample that we had collected was from that hospital bucket. So the person who gave the sample to a clinic when they were sick didn't know that their sample was going to be tested for SARS-CoV-2. So what did we do? So we felt like we were sort of in this situation where we were pretty sure that our test worked. We then had sequencing results that validated that it was SARS-CoV-2. We also had confirmation from the state lab at the time that it was SARS-CoV-2 by their assay. We thought, well, what do we do? So we decided to notify the participants through Seattle Children's Hospital. And at the time that they got the text message, they were on their way back to school after being out sick. And so I think the fact that they were notified prevented the exposure of an entire high school. So I think it was timely that it happened when it did. And probably had we waited longer, we would have had a worse outcome. So, when I think about that time period, the things that we have talked about since then and that we continue to talk about is, is it ethical to withhold results of a test that could potentially alter the course of an individual's illness and society's trajectory in a public health emergency? And particularly during a public health emergency, how do you distinguish research from public health? So research activities are governed by the common rule, which protects human subjects, but public health surveillance activities are exempt. But public health surveillance activities need to meet these specific criteria, being able to provide a direct link to decision-making and action by a public health authority such as CDC or Public Health Seattle-King County. So what we were doing at the time, which was research, did not fall under this public health surveillance umbrella, even though the results of our research then ended up actually being quite actionable and important for decision-making by public health authorities. And so can we develop a system in the future where during times of pandemics or public health emergencies, that research can be repurposed for public health? Is there a more streamlined way to make this happen? We have the biospecimen repositories, we have the metadata. In all of our other samples that we collected from the community, individuals were consented to have their samples tested for all respiratory pathogens, not just flu. So there are ways to make it so that we have a set of samples and a set of data that's ready to go. And so how do we make it happen for next time? So then I think here are the results. So we went back and we tested all the samples back to December, found that very first positive was from February 24th. We did the sequencing. We showed that there was ongoing transmission in Washington State between the first sample and the second sample. And then we shared the information through Trevor's tweets, and then ultimately picked up by the New York Times, and then also with public health. So I think the lessons that we learned from this period of time, you need flexible consent, that early consultation and development of standard language with human subject boards would to allow for research samples to be tested for novel pathogens, for this data to be used effectively is really, really important. That laboratories at major academic medical centers can develop assays quite quickly. And we should be leveraged during times of public health emergency, that it shouldn't be restricted to CDC or the state health labs, that there's really a lot of talent and ability to develop these tests quickly here in academia. That this electronic data infrastructure is really essential, that the fact that we had built a system where you could link the two was really important for us to be able to make that identification very quickly. And that the regulatory landscape around diagnostic testing for novel pathogens really needs to be simplified tremendously in times of public health emergency. The amount of information I learned about sort of regulatory guidelines about diagnostic testing was well more than I think any clinician knew at the time. And I learned it within probably 72 hours because we had to figure out what to do. And I think that it seems like it should be simple, but it really was very, very complicated and very difficult to navigate this particular situation. And I think one of the things that really helped us was having real-time ethical consultation. We were able to talk to the head of human subjects at UW on a regular basis to ask them, what is the right thing to do here? What can we do? What can't we do? And they gave us a lot of guidance during that time. And I think that needs to be part of pandemic response, which I don't think is something that we intuitively think about, but at least something that we found to be really, really important. Okay. Okay. So in the last part of my talk, I wanted to talk about Harvey, which is this human cohort study that we also established at about the same time as we first identified the US case. So based on just having been part of a lot of studies in the past, what we knew intuitively is that biospecimens were really important to be able to be used for a lot of the early trials of vaccines and for therapeutics. And we knew that the biospecimens from individuals recovered from COVID-19 were really, really critically needed early in the pandemic to see if vaccines could make the same antibody response as the source of monoclonals, and then to understand how long immunity lasts and to identify early indicators of disease severity. And we knew that transfer of biospecimens across international borders was incredibly challenging because people often don't know the biohazard risk of the specimens early in a pandemic. So it takes a lot of time to figure that out. And then to get the data transferred is just very, very hard. Unfortunately or unfortunately, Seattle, Washington was the site of the first US case. And we had an ongoing research study because my interest is in the immune response of adults with respiratory viral infections. So I had an ongoing research study of adults with respiratory viral infections. And then within days was able to take this study and add SARS-CoV-2 to it, and then start enrolling people who had recovered from SARS-CoV-2. So we enrolled the very first US patient. This is Jan England, professor of pediatrics. The first sample is in that cooler right there. And it was actually the sample that went on to become the source of the monoclonal antibody that Eli Lilly is now developing. And then also was the sample that helped develop the Moderna vaccine. And then afterwards, you can see we didn't have masks on. The only thing I was asked to do after enrolling these patients was to monitor my temperature for 14 days to make sure I didn't develop a fever. So that was back in February of 2020. And then what we did was we started collecting these samples from these individuals very early. And this is one of the very early studies that we did, which was published in summer of 2020, where we looked at the antibody profiles of those who recovered against those who died. And this was work that we did in partnership with Gilly Alter and Carolyn Chio at Reagan Institute at Harvard. And what you can see here is that you don't really have to look, it's pretty clear. The people who are convalescent, they seem to have a more coordinated immune response to the infection, whereas the ones who died had an uncoordinated response. So sometimes certain antibodies went one way, certain profiles went one way, and then there's a lot of sort of disorganization in their immune response. This is really important because it helped us early on to identify what is a sign, what is a marker of success. Now, what are you trying to achieve with a vaccine? You're trying to achieve a coordinated immune response. You're trying to avoid the disorganized immune response that was associated with death. We also used that cohort very early on, back in early in 2020 to sort of better understand long COVID. And this was one of the first reports of long COVID in the United States in outpatients. And so we asked individuals who had been enrolled in Harvey whether or not they had signs and symptoms of long COVID at 6 months. And we found that 30% of the individuals in our study had long COVID. And this was, I think, startling at the time and confirmed now with multiple other studies. And what we wanted to do was to take that data and sort of better understand, what are the predictors of long COVID? So at the time it was picked up by a lot of the media because I think it was very alarming. It was mostly patients with mild disease. 30% of them had long COVID. It was covered by Dr. Fauci at the White House briefing. And then we subsequently went on and we started looking now out to 2 years. And what we're finding is that actually these symptoms are continuing, that people who have been followed since March of 2020 are continuing to have symptoms of fatigue, of loss of sense of taste and smell, of brain fog, that these are persistent out to 2 years. And so we haven't published these data yet, but what we'll do is continue to follow these individuals over time. One of the other things that we did was we partnered with a group at ISB and at Swedish, led by Jason Goldman and Jim, to understand what are some factors that predict development of long COVID out to 6 months to a year. And this was a study that was done where we found that having autoantibodies, having a high viral load, and having pre-existing conditions such as diabetes were associated then with the development of symptoms of long COVID. And this was an early study. It was only a couple hundred individuals, but it now has allowed us to really expand this cohort and to partner with many institutions around the country as part of an NIH consortium called Recover, where we're enrolling thousands and thousands of individuals in the United States now to be able to understand what are the factors that predict development of long COVID and to identify potential early interventions to stop this. So the other thing that we've done with Harvey, which I think has been really important, is that we've been able to follow these people through their infections, their vaccinations, their boosters, and through their breakthrough infections. And that has allowed for some really interesting observations about durability of immunity and about breadth of immunity and about the type of immunity you get from each type of exposure and how it subsequently protects you from later exposures. And this is just an example of one of the papers that we published led by Davidbiesler here at the University of Washington, where we looked at individuals who had recovered and who had received all of these different vaccines. And we wanted to see how they did how they performed against the different variants. And what we found was that people who had gotten vaccinated at least 2 times didn't do that well against Omicron. But that third dose, or somebody who had been infected and then received 2 doses, they did quite well. And it was one of the very early reports of the value of boosters and the values of something we call hybrid immunity, which is if you get an infection, then you get 2 doses of vaccine. And that combination controls your ability to respond to the novel variants successfully. And so we've done more of this work with David and with others here at the University of Washington and all over the country to really sort of understand what is a successful response and can we predict what's going to happen with the new variants, with BA4, with BA5, as they emerge and enter into Washington. So the lessons learned from Harvey, early samples from convalescent individuals allowed us to rapidly develop vaccines and monoclonals. People have symptoms of long COVID well past their initial period and now up to 2 years. And we found some early markers that predict development of long COVID. And individuals with multiple doses of vaccine or those with vaccines and infection have higher levels of protection against the novel variants. And I think what really seemed important for me is that, again, this is something that should be in place before a pandemic and that can be rapidly scaled up at the time of a pandemic. Having these prototype consents and protocols, having a hierarchy for who's going to get what sample, and all the contracts that you need in place to move the samples from place to place and to transfer the data, that takes a lot of time. And I think if you spend the time ahead of time to get all of that in place, it makes the process much faster. That it actually didn't cost us that much to have Harvey up and running before the pandemic, it was something like $20,000-$30,000 for us to be able to have this in place. And that's not a lot of money for what we were able to accomplish with that early infrastructure. And then one of the other things was sort of around the idea of sort of the remote consent and enrollment, and having the ability to collect biospecimens, manage biospecimens, and ship biospecimens that are all potentially hazardous, and having the people who knew how to handle those and the protocols in place. That all needs to be in place ahead of time for you to have an effective response. So, so just at the end, I just wanted to show you what we're working on now. So as some of you may know, we are doing the University of Washington testing. It's called Husky coronavirus testing. Many of you may be in this study. We use many of the same protocols that we use for Seattle flu study. So people come to the kiosk or they sign up on the website, then they enroll in their study, and then they collect a nasal swab. We have used this to, again, show how different variants have spread throughout the University of Washington. Here is a phylogenetic tree on the bottom, and the yellow is Delta. At the top in blue is Omicron. This is led by Anna Weil and Amanda Casto, who are faculty members in infectious diseases. What you can see here is that Delta sort of, came in, it spread. But then when Omicron arrived, it really explosively spread in the community. And this was despite 99% vaccination and fairly maximum use of MPIs at the time. So it's pretty alarming. And it sort of gives us an indicator of what is to come. This is also work we did with Snohomish Public Schools. This was a study where we wanted to understand how do you test little kids in school and to keep them in school. And so we tried two approaches. The first approach was to send kids home with the parents and expect them to bring it in after they test the kid every week. And the other approach was that just to have our research assistants go to the classrooms and test the kids. And we found, as anybody with young children knows, is that having the research assistants collect the swabs is a much better way to get the samples. That it's very hard for busy parents to be able to collect a swab and bring it into the school. So I think if you have a model for testing in schools, it really needs to be done on site in schools and not rely on the parents to do it. I don't have time to go into this, but we do a significant amount of work in the homeless shelters in Seattle. We've partnered with Mary's Place, with DSC, with St. Martin's. We've done some pretty important studies looking at transmission of viruses, looking at vaccine hesitancy, mapping how COVID-19 spread in the shelters, because we were doing respiratory virus studies in the shelters before COVID-19. So we were there when it started. So we were able to continue our work. And that's been really important, I think, particularly from the perspective of the shelters, because it was one of the few ways that they actually had more available testing early in the pandemic than anybody else in the city, because we were testing 6 days a week in the shelters. And I think that helped actually control a lot of the transmission in the shelters at the time. And then finally, I just wanted to show this, which is how Seattle has now become in many ways a way for us to look at how respiratory viruses in a city sort of ebb and flow with the different interventions that you might want to put in place. So you can see here, of course, is that you see all these viruses year after year, and that in April of 2020, with the Stay Home, Stay Healthy order, basically complete elimination of all viral transmission in the city. And now what we're seeing now over time as we head into 2022 is that these viruses are now coming back. And so what we'll be able to do is to look at all of these viruses, see what the interventions do, and then to be able to sequence these viruses, and then also just to answer interesting questions about diversity of flu, for example. We think flu B is gone, flu B Yamagata is gone. Is that actually true? Or did it just go away for a little while and it'll come back? So we can answer those questions. So finally, I'd like to acknowledge everybody in my lab who did all the work, as well as all of our collaborators at Seattle Flu Study, including Zach here. And then I'm happy to take any questions.
That was an amazing talk. I was moved. I was inspired. I was scared at times. So I appreciate that. I would love to open it up to anybody here in the room who might have a question right away. But yes, Dr. Hill. Yes, I do.
Thank you so much for the talk. It was amazing to hear about all the work we did and how important it was. I'm kind of curious about the human element for the researchers in all of this. I was thinking about that, the timeline you have of those early days after the first case and the first case here, and you're not sure whether to release the information. And I was just wondering what it was like, if you feel comfortable saying, for the team of researchers to kind of confront this information. And you alluded to the fact that not everyone maybe was on the same page of how serious things were going to be. And so I just wondered what that experience was like, and how you all handled it as colleagues.
Yeah, I mean, it was a tough time because I felt like we didn't have the same perspective. I think, we were on the same page as local and state public health. All of us were pretty certain that there was COVID here in Washington, that it was spreading, and that we needed to find it. And so we needed an effective test that we could deploy quickly and start looking. Whereas I think at the federal level, there was not that sense, or at least that wasn't what was perceived. It was that the biggest concern on their part that was told to us was that they were afraid that we were going to find a false positive and lead to hysteria. And that was going to be the problem, that they did not want us to do testing that could lead to people thinking there was a pandemic when there actually wasn't.
Do you have a follow-up question back here?
So my question is, in your opinion, are we at the beginning, the middle, or the end of this pandemic?
I think we're in the middle to end. Yeah, we're definitely past the surge. I think it'll still, it's going to take time to transition to a seasonal virus. We're not there yet, and there's, multiple variants that are continuing to arrive, and much of the world is not immune. So I think that we'll continue to see variants arrive, and then the question is, how bad will it be year after year? No, I think the worst is past. I do think the worst is past because much of the population has acquired immunity, right? So either through infection or vaccination. And so the variants that continue to infect us will be encountering us with some pre-existing exposure to the virus, at least most of us, here in Seattle, here in the United States, and in some parts of the world. But sort of the wild part is, is there going to be another variant that's going to be so different that it's going to lead to another massive wave? I think it's less and less likely as time passes.
Thank you for this great talk. When you were telling your story, you didn't focus on the politics of this case, because of course we've all been living that. I'm wondering if you could reflect a little bit about the way that public policy, or the implementation of public policy, could have shaped this difference. Not the politics, but the policy. So one of the things you talked about is the regulatory constraints you face. I think that's because oftentimes that kind of policy has been passed to control things that can be controlled. This clearly is a case where that tool of policy wasn't very useful. But I'm just curious about your sense of how could policy at the federal, state, or local level been perhaps more tightly connected to the research, or I'm just curious.
Yeah, it's something, I've been thinking about a lot of, what are sort of the policies that we can put in place moving forward that would have made it easier. I mean, I think there's clear value for a lot of the rules that were in place, right? It's really important to have people who are enrolling in research studies be protected. And I think that for me was, it's clear that needs to be the standard. But we need more flexibility, and in times of emergency to change that. That just because you no longer fit doesn't mean there's no path whatsoever. But things don't move that quickly at the federal level. I mean, it was clear this entire time that we were the wrong group to be finding it. That if we were a state public health agency, that we would have been taken much more seriously at the time than we were as an academic research lab. that because we're not the right group to have been able to find the virus. And there was just sort of a difficulty in sort of knowing what to do with the information, even if the information was true, just didn't come from the place that it was expected to come from. Mhm.
Built over around the public health funded system.
Yeah, so I think that, well, I think a lot of the public health infrastructure that was in place was not equipped to be able to do what it needed to do at the time. And we had all this funding, we had like all of the modern systems, we had academia, and so we could develop things sort of outside of public health that could pivot so much more quickly than public health could. And public health has been poorly funded for a long time, and I think, especially public health labs, that I think that it would have been very difficult for them to have been able to respond effectively with the amount of funding they had had over the years, and with the lack of infrastructure for sort of data management. The things that we had built sort of in the academic world were not things that existed in public health.
Dr. Chu, someone on the Zoom wanted to know how or what lessons your team has taken away from our experience with mass vaccination during COVID-19 and some lessons for the future.
Yeah, I mean, I think the main thing is that uh, there's just an erosion of trust, right, in public health authority, and the ability of our sort of CDC and public health colleagues to be able to convey information, and that we needed to probably spend a lot more time on the implementation part of things. I don't know that I necessarily learned it from the Seattle flu study, from the follow-up work that we've done since then, but it's become clear that that the point at which we tripped up was sort of the implementation of the vaccines, not the development. So that there was not really any work that was done ahead of time, or not enough work done ahead of time to educate, to answer questions, to build the trust, to be able to get the vaccinations out the way they needed to go out.
Thank you so much for your great talk. I have a question about the research side. So, this is my first time to hear pandemic and how pandemic is going on in the world and individual life. But it is awful and painful experience for individuals to go through the pandemic. But at the same time, it is great opportunity for international collaboration in the medical field and policy field, and etc. So from your experience, what was the great thing that you learned from the international collaboration, if you did kind of experience? And then what was the biggest challenge you kind of feel in terms of tackling this kind of challenges, sharing information and ethical concerns, or tackling those different stages of policies or differences? What was your experience telling about the opportunity and challenges of international collaboration for this kind of like issues?
Yeah, I think it was actually very difficult to have international collaborations during this pandemic in terms of sort of the very early work and for data transfer and sample transfer. Certainly the sharing of the knowledge and the interactions that happened after the data was generated was much simpler. But the fact that you couldn't move specimens or data was a real barrier very early on. I think the thing that would make it much better in the future would be to simplify that process. But I understand why it's hard. If you don't know how pathogenic that sample is, it's going to be very hard to move that sample across an international border. And it's not because people don't want to move it. It's just because there's so many other things that are keeping it from going through. So I do think that the value of the international collaborations has been in sort of the data exchange, and then the things that have happened more recently, but not early on. That was very hard.
Thank you so much for your talk. I kind of have two questions within very different places. The first one is, it really seemed like during the flu study, you guys had developed a lot of the best practices that ended up just being adopted, such as like home test kits to be able to test and send in. And I was wondering, do you feel like some of those best practices aren't shared enough that maybe, like done within the academic world or the research world are not shared enough with state and federal policymakers?
Mm.
And then, where could a platform be opened up that would allow for that to happen? Yeah, that would be my first question.
Yeah, I think it's challenging, right? Because we live in our academic world, and the way that we traditionally disseminate data is through publications and talks, and that's just going to an audience that's not necessarily going to be the policy audience. So, I mean, that's a struggle. I do think that a lot of the work that we've done has been picked up and pretty widely disseminated by people outside of academia. So that's actually been quite new to me. The fact that the actual ability to communicate outside of just academics, and it has, I think, made its way into the hands of policymakers, and a lot of the work that we do is now part of guidelines for infectious diseases and diagnostics, and it's cited. So I think it has become part of policy. It may have taken longer than, but this is lightning speed compared to how academic research usually goes. Yeah, it's been a really, that's a great question. It's been a really interesting sort of evolution, right, over time, because traditionally you would just think your national public health agency is your voice, and that we as scientists communicate our findings to them. They interpret and they disseminate. And so I think very early on, that was my view of, this is what we need to do. We provide them the information. But what became clear during the last administration was that that was not happening. That that information that was being provided, scientific information, was not being translated into policy. And so the voice of trust was just not present. And I think that's when sort of everybody swooped in and started, having their own opinions and all of that. And I don't know, it seems like it's a hard time. I don't know what the right thing to do is. This is not my field. My field is vaccines and virology. I don't think I'm necessarily the person to be communicating directly to the public. I think that needs to go through CDC, but that just hasn't gone that well. Yeah. Yeah, I mean, obviously the biggest failing was the inability to get vaccines out, um, and the inability to share all of that early on. It's it's a struggle because a lot of the technology required to develop these vaccines was developed here. And how quickly do you get it out to other countries? That's not my expertise. I wouldn't be able to comment on that. But I do think that building the infrastructure for faster diagnostic testing for the the things that need to be in place to be able to put the vaccine together, the labels, the vials, the stoppers, all of those things, putting in place the QA/QC things that are required for manufacturing in other countries seems like something we really should be investing in now. because it is very likely that we will have another global pandemic. And we weren't able to do it this time. It was a complete failure. So it does seem like those systems need to be put in place. I just don't know that I'm the right person to be able to say how to do it. That's just not what I do. Oh yeah, I mean, at least for other pathogens, diagnostic testing for other pathogens seems like, and treatment, I think there's clear role for expansion outside of the clinic. That people are clearly able to do a lot of things on their own that we didn't think they were able to do. And so being able to say diagnose flu or diagnose RSV or diagnose strep throat or diagnose all of these things seems to be able to be done in a remote way and handled remotely. So I think there's definitely value and just sort of telehealth and the ability to reach rural areas and underserved areas. That has been a real sort of game changer.
Okay, so my second question was that you kind of spoke to post-COVID taking up to 2 years to move past in some cases. And I'm just curious if you have any idea on the causes of the drawn out symptoms, or if there's been any progression in that.
Yeah, so I think there's been evidence of long persistent symptoms with many viral infections in the past. I just don't think that we've had the numbers of individuals affected to be able to sort of really have it be something that's I think of enough public interest to justify this type of discovery work up until now. Ebola, for example, we know that Ebola causes persistent symptoms for a very long time. Zika, chikungunya, all of these things, all of these other viruses have done that. They just haven't affected the populations or affected enough people, I think, for it to raise this level of response. So I think that it does trigger some sort of autoimmune cascade, but how that trigger happens, when it happens, and what you can do to prevent it, I don't think that we know enough yet to say. But it's not new. I think these sorts of persistent symptoms after viral infections have been well described with other infections.
Hi, thank you for your presentation and thank you for your service too. Really, this is so remarkable. So my question is, what led to setting up the Seattle Flu Lab? Like, was that just a coincidence in 2018? Like, what led to that point? And then,
Yeah, we were contacted by Bill Gates because he was concerned about the next global pandemic. And he contacted a group of us and asked us if we could start thinking about how to better prepare for a pandemic. And so we conceived Seattle Flu Study because, we studied flu, and we thought that would be the next pandemic. And then it was really just a matter of meeting with a lot of people and asking them, what do you think is missing in our current infrastructure? And then trying to figure out what we could create with a lot of resources in a city to be able to start testing out some things. So we thought of Seattle Flu Study as sort of just a way to beta test a lot of things that we thought might work.
Hi, I want to thank you for the work of all your team as well. It's been kind of fun and amazing to be so close to that work. Many of us participate in the study, so we feel like we're doing our little baby part and helping make things better, but really appreciate the work. I kind of wanted to ask you to speculate a little bit outside your expertise as well, and talk a little bit about the lessons, or if you could pick one or two things in the public health infrastructure system, you would these, in East Africa and Rwanda and Ethiopia, and I was amazed at the speed at which those public health systems mobilized initial responses because they were set up because of Ebola, because of previous pandemics. Now, capacity-wise and infrastructure-wise and testing-wise, it was a different story. But in terms of their ability to turn on a dime and start at least temperature testing and putting things in place, it was incredibly rapid and quite encouraging to hear. So I'm just curious, at the end of this and looking back, wave a wand and change one thing about our public health system or make one investment, what might you try to do to get us better prepared for next time around?
Oh, there's so many things.
You can pick 10 if you want. I
I-
didn't want to put you on the spot.
No, that's a really good point. I think data infrastructure is the thing that we need more than anything else. That things can't be on paper and on faxes. That they can't then be transcribed from the faxes into an Excel spreadsheet. That there's just too much error in that, and that doesn't have to be this way. That we can be much better at this. Many groups. This is not that. That seems like a fairly addressable problem, and it would solve a lot of helping us to be able to answer questions quickly. So if I could invest in one thing, it would be building up a better public health data infrastructure. Wouldn't it be great if we could know how many people got vaccinated on a national level in the same way that Israel and the UK could?
So that this reminds me of a question that I've been talking about with many of my colleagues who are part of the Husky coronavirus test. I would love to know how you all use those daily text message surveys that many of us complete, and what, kind of how that contributes to science.
Oh yeah, I didn't have time to go into all of it, but I'm happy to come and talk to you again about the amount of work that we've done with the Husky testing study. We've done a lot of work looking at outbreaks. We found what happens in an outbreak, how does it spread, what is the time interval between the first case and the second case, how quickly do certain variants replicate in this closed community, what are sort of the hotbeds? They're usually the Greek houses. And sort of what are the sentinel sites, also the Greek houses. So I think there's been a lot of information that we've been able to gather. There's a little bit of sensitivity about how we share that right now, because I want to make sure that it goes to public health first and that they have that information and can make decisions. And then I, in some ways, also just feel sort of hesitant about sharing raw data with the general community without it being vetted through like sort of the traditional academic platform of, manuscripts and peer review. So I don't know. I mean, I don't know what the right thing to do is, but that's my personal view. It's I want someone else to look at it and objectively review it before I would share it more openly. But we've now published 2 papers on Husky testing, and I can share those with you.
Thank you.
No, I appreciate your answer, and that brings up like a follow-up question. I think there are 2 schools of thought when it comes to health at the population level, right? There's the school of thought that prioritizes the biomedical approach, which is like we could always have more testing, more of all the things you were just talking about. Or we can, invest in sort of social policies, things that are less reactionary, right? And invest in a population that's just resistant to a pandemic generally. And so the question is like, have you given critical thought to the limits of the biomedical approach to population level health? Have you thought about how sometimes policy leads to research versus outcomes leading to policy?
Yeah, no, I hear you. There are clearly limits to what vaccines and testing and masks can do without some substantial work on sort of education and investment in the community and just sort of the community health infrastructure, right? So I think of, what if we had a national health system? We wouldn't be in this situation that we're in right now. So there's just so many other things that we should be working on right now, and that to me seems like a better use of resources than, this reactive response that we are currently engaged in. But we have to get past this phase first, and then work on those other things.
All right. Thank you very much for the talk. It was exciting to hear about a program that may be real happy to be in Seattle during the whole duration of this pandemic compared to somewhere else. My question would be more about the vaccine side of things. So during this pandemic, we saw how fast vaccine development could be in comparison to vaccines that came along before, which would usually take somewhere in the span of decades. But it still did take almost a year to develop this. And there seems to be some efforts to speed up this process. I think I've heard somewhere within 100 days. What would you suggest to accelerate this process further to make this 100 days perhaps realistic? And are there any other things that you would suggest for the next pandemic that comes along for vaccine developers or scientists to implement?
Yeah, I think a lot of those things are happening. So I think we know what the viruses will be, or the pathogens that will be, that will likely lead to the next pandemic, and they fall into the sort of the coronavirus, the flavivirus, the influenza virus group. That's not the right term, but those types of viruses. So, and there's a lot of work being done on sort of prototype vaccines based on the conserved regions. And a lot of the technology, mRNA and the adenovirus vector vaccines are now they're so much faster. I don't think that's going to be our problem. I think the problem is going to be the implementation again. That sort of the amount of vaccine hesitancy in the community, both locally, nationally, and globally, has just going up tremendously over time. And that it's going to be harder and harder to get people to take vaccines unless we do something about global vaccine hesitancy. So I think that we're actually in pretty good shape on the development front. I think it's going to be the implementation that's going to be, again, our stumbling block, unless we do some significant work to build trust in public health.
So I think I'll close this out with maybe a two-part last question. One, I would really be interested in hearing you reflect about how you and your team have managed the stress of working in this moment over such an intense period of time with where the stakes are so high, and the narrative and story you provide about the student going back to school with the test result, like it really kind of puts it, in a real poignant way for us. I'd love to hear your reflections there. And also, I'd love to hear your reflections on how you think your research career and path is going to be changed or fundamentally altered by this. I mean, I know you started the flu study in 2018, but this has taken turns that you couldn't imagine. So I wonder what you think the future holds for you and your team in terms of research.
Yeah, I think it's been hard to actually even take a step back, because it's just been one emergency after another for the last 3 years. We're not sort of in the period of time, I think, for any of us where we're sort of at a pause point where we can actually reflect yet. I don't know when that'll be, but right now I think we're also in crisis mode. There's just, Omicron, Delta, the next Omicron. It just keeps on coming, and every week is still a crisis. And it's been, I think, hard for us because I think we understand the science of, why you need to continue to mask and why certain things need to be in place. But the policy has not really harmonized with the science in many places. And so that's been like, as the people who have to deal with sometimes the consequences of these policies, it's been very, very hard because it's a lot of work to, process 1,500 tests a day because we lifted the masking mandate. Now everybody has Omicron. So I think that's just continued to be difficult. I hope that we get to a period where we all get to take a step back and think about the future. I mean, for me, I initially started in sort of global implementation of vaccines and maternal vaccines, and that's ultimately where I'd like to get back to, sort of the global vaccine work. And work that we do, sort of making sure that we get vaccines to the places that they need to be. But I think that's a long time coming. There's just a lot of other things I have to be involved in for the next couple of years until I can get back to that.
Well, everybody on Zoom, thank you for coming in. Everybody here, join me in thanking Dr. Chu for her comments and project.